So let's now start with the thoracic wall first. In the thoracic wall, guys, first we'll be looking at how exactly the thoracic wall uh, provides you certain landmark based on which you can divide the mediastinum also inside. So to start with, let me take a sagittal section, and in the sagittal section, obviously you will see the sternum bone anteriorly and the vertebral column posteriorly. So just a very schematic view of the sternum. Let us say there's a manubrium of the sternum. Here is the body of the sternum, and this here is a xiphoid process. So you're looking at the manubrium. This here is the manubrium. I'm writing M for the manubrium. There goes the body of the sternum, and this X is for the xiphoid process. Let us presume this line here represents the vertebral column. If guys, this here is the vertebral column, then this represents the inlet of the thorax. This oblique line I'm showing with the green color here, it represents the inlet of the thorax. And here is the diaphragm, which is the outlet of the thorax. These are the two major topics of concern for us here. In this, that is inlet of the thorax and the outlet of the thorax. Let me mark that. This is inlet. Inlet of thorax, which is also called as the Simpson's fascia. There's a fascia over there which is called as a Simpson's fascia. We can also call it the suprapleural membrane. So this is Simpson's fascia or suprapleural membrane. We will come to that. And this one here is the outlet of the thorax, and that is, we all know, is by the diaphragm. Before we move on to the inlet and the outlet, and we'll discuss in more detail, I hope you know that manubrium and the body of the sternum, this angle between the two is called as a sternal angle or the angle of Louis. Now, this is a very, very important landmark here, guys. This here is called as the sternal angle. I'll tell you more about the sternal angle or angle of Louis. The point is, if you draw a horizontal line from the sternal angle, if I just draw a horizontal line, imaginary line from the sternal angle and stretch it posteriorly, you will see it passing along the lower border of the fourth thoracic vertebrae. So that's the lower border of T4, and that is the exact level of the sternal angle if you see it. Now, by this imaginary plane, we are basically dividing the thoracic cavity inside, or I should say the mediastinum inside, into two parts. We got a superior mediastinum and the inferior mediastinum. We all know mediastinum is the space between the lungs. So the space between the lungs can be divided into broadly two parts. First, one is superior and one is inferior. But one major structure present in the inferior mediastinum being heart. So let us say if this here is the heart and the pericardium, let's say this heart and fibrous pericardium you're looking at. So that further divides the inferior mediastinum into three parts. So we have anterior part, middle part and posterior part. So overall I can say this here is the superior mediastinum, and inferior mediastinum divides into this one anterior mediastinum 1, this is middle mediastinum 2, and here is the posterior mediastinum. So we have three parts here, AM, MM, PM, that is anterior, middle and posterior mediastinum. Middle mediastinum, as we said, it is all about heart and its great vessels and pericardium. Radiologically, they usually do not talk about superior or inferior mediastinum. They simply say anterior, middle and like posterior. So they basically consider this extension of anterior mediastinum above, middle like this and posterior like this. So you will find certain terminology which are a bit different, like when you read it in the anatomy and then into the concerned clinical subject. So you might not hear the term called as superior mediastinum in radiology. So that is okay. I mean, anatomically we divide into superior and inferior divides into three. Before going into the inlet and outlet, that is the main topic in here, let's first talk about the sternal angle. What is so important about this sternal angle, guys? The sternal angle which is approximately 5 degrees only, this sternal angle, it is also called as the angle of Louis. This is also called as the angle of Louis. And why this is so important? Because this is a major landmark for many structures in thorax. Like if I start with the bony thing, the sternal angle or manubriosternal joint, or this junction here, it is the point where the second costal cartilage is attached. When you count the ribs, then the most the reliable point for the counting of the ribs would be the second rib or the second costal cartilage, which is attached exactly at the sternal angle. So this is the point where the second costal cartilage is attached. It's very, very important, clinically very important to know that point, level of the second rib or the second costal cartilage attachment. What other important things you will notice at the sternal angle? I mean, because when you talk about sternal angle, we are talking about that lower border of T4. So either you say sternal angle, or you can say we are looking at the level of lower border of T4. What other changes you will expect to see at the lower border of the T4? And they will be, the other one change we already saw that when we draw an imaginary line, it divides the superior and the inferior mediastinum. So this level here is a division of the superior and inferior mediastinum. Okay, what else? It's a very important landmark for the bifurcation of the trachea. Now I'll add something to this, but you can write it first. Bifurcation of trachea. Bifurcation of trachea takes place at the lower border T4. That's how it's always been said. But if you look at certain updates in the latest Grays and on some other books also, they mentioned that when you say bifurcation of trachea, this is basically a cadaveric level we talk about. In cadavers, when you look at this, okay, lower border of T4, that is the right answer. But in living, the bifurcation of trachea is not at the lower border of T4, it is actually at the lower border, or you can say at the level of the T6. So it's way lower than what we see here. So lower border of T5 or the body of T5, or in fact it can even extend to the T6 vertebrae, that is a bifurcation of trachea. So it does vary from person to person. I mean, that is how it is mentioned. There is a complete statistics given regarding it in the Grays also, that a certain percentage shows the division is at the T5, certain that shows even below the T5. So that, and even deep inspiration, it can go even further down. It can reach almost till the level of T7 also. So when you say bifurcation of trachea at the lower border of T4, the one thing that you have to keep in mind is that here we are talking about the cadaveric level. This sternal angle, what other thing we have here? This is the level for the arch of azygous. When arch of azygous vein will come and drain into superior vena cava. So this is done exactly at this level only. So the arch of azygous drains into superior vena cava. We will discuss that, how exactly the arch of azygous is coming and draining into it. You can write it down for now. That arch of azygous vein will come and they drain into superior vena cava at the level of T4. This is the level for the beginning and end of arch of aorta. Be careful about this. I'm not saying it is the level for arch of aorta. No. Arch is present at the T3 level. That is higher level. T4 is the point where the arch of aorta begins and it ends. So if you take a transverse section at the level of T4, you will not see the arch as such. You will see the two vessels, one in front, one behind in the transverse section. We will discuss that at the end. And that is beginning, basically the initiation or the beginning of arch of aorta, and the other would be the section through the end of the arch of aorta. This also is the level for the apex of fibrous pericardium. This is the level for the apex of the fibrous pericardium. Please remember one thing, when we talk about pericardium, the serous pericardium is the one which behaves more like a heart. I mean, if you look at the base of the heart is posteriorly placed and the apex of the heart is toward the left side. And that's how the serous pericardium is covering it. But the fibrous pericardium is like a pouch in which the heart is placed. That's how you should take it. So for the fibrous pericardium, the base of the heart and the apex of the heart doesn't matter. Fibrous pericardium is like a pouch in which the heart is placed. So base for the fibrous pericardium is below and the apex is above. Unlike heart, which is having the base behind and the apex more toward the left side. So apex of fibrous pericardium, it's fibrous. pericardium, which is also reaching the level of the T4. This also is the level for the location of the cardiac plexus. We'll discuss these cardiac plexus, superficial and deep cardiac plexus. They are lying more or less at the level of the sternal angle only. This is the level for the attachment of superior sternopericardial ligament. Attachment of superior sternopericardial ligament. There are two sternopericardial ligaments. One is superior, one is inferior. That basically is attaching the sternum bone to the fibrous pericardium. So we have a superior sternopericardial and we have inferior sternopericardial. So superior is the one which is present at the level of the sternal angle. Another landmark to be remembered. Then one very, very important thing, that is thoracic duct. Guys, thoracic duct, it runs in the center. We will again discuss that in the later part. Thoracic duct, the largest lymphatic duct of the body, runs in the center. And then this thoracic duct actually deviates toward the left side to drain into the junction of internal jugular and subclavian. So what is that level of deviation? It starts deviating at the T5 only. When you look at the fifth thoracic vertebra, it starts deviating at the T5 only, and at the lower border of T4, or you can say at the sternal angle, you consider that the duct has come toward the left side now. It is now completely come toward the left side. So the thoracic duct deviates to left side. Thoracic duct deviates to the left side. That is also happening at the level of the sternal angle. And there are many other things. I mean, you can keep on adding to this list. This goes on and on, but we just have to look into the important one first. I would say out of all these, the one which are the most important here, one is the second costal cartilage attachment is very important. The bifurcation of the cadaveric trachea, that is another important. Arch of azygos is important. I would say this thoracic duct one is important. So very precisely for the exam point of view, out of all these, I would say that these are the ones that you should remember all the time. After the sternal angle, now let's move on to the inlet and the outlet of the thorax. So guys, let me just take you back here. So we said inlet and the outlet. Now first look at a picture here in which you can see how exactly things will look like, and then we'll go into more details of the inlet and the outlet part. Here is the one. This is the kind of picture we drew. We can see the sternum there. We can see that is the manubrious sternal angle or angle of Louis. You can see the vertebral column there. That's 1, 2, 3, 4 thoracic vertebrae. And can you see that line over there? You can see a difference in the color, which is showing you this imaginary line which is dividing this superior mediastinum, and this whole thing here is a inferior mediastinum. And you can see the inferior mediastinum is further divided into anterior, that is blue one here. This orange one here shows the heart and obviously related blood vessels, so it is middle mediastinum. And everything at the back here is a posterior mediastinum, in which, as I already said, will be the descending aorta. There will be esophagus, thoracic duct, sympathetic chain, azygos, hemiazygos vein, and many other things. Very, very important mediastinum to be discussed. That is the one posterior. So now we're going to talk about, one is the inlet of the thorax, from where the structures of the neck will go into the thorax, or thoracic structures goes into neck from here. And then we will talk in detail about this very, very important topic, that is the diaphragm. How it is attached, what are the openings in the diaphragm, what structures are passing through it. So there we go. The inlet of the thorax, which we said can also be called as the Simpson's fascia. It is also known as suprapleural membrane. It is present above the pleura, so you can obviously call it supra. It is also known as the suprapleural membrane. Now, it is believed that this Simpson's fascia or suprapleural membrane, it is a remnant of the muscle, and that muscle is the scalenus minimus. Well, we do have scalenus anterior, scalenus medius and posterior, so there is no question about the remnant. So it's a remnant of scalenus minimus muscle, which is called as a suprapleural membrane or Simpson's fascia. The question here in the Simpson's fascia is that they do ask question about the attachment of this fascia here. Because, when you think about the inlet of thorax, the thing that should come to your mind is, okay, the inlet has to be somewhere at the superior border of the, the sternum, and it should be till the T1 vertebrae. Now, obviously, T1 is the vertebrae from where the thorax starts. But no, that is the important thing to note here. that the attachment of substance fascia posteriorly is not to the T1 vertebrae, it is actually to the C7 vertebrae. Let me diagrammatically represent this to you. So what I'm saying is, if this here is the body of C7 and let's say this is a body of T1 vertebrae, that is C7 and that is T1. Here we have their transverse processes. Obviously the first rib will be attached to the T1 only if this is the first rib here. No question about that. The first rib is attached to the T1 vertebrae only posteriorly. And this here is the manubrium. So that's the transverse section that we're looking at. This is the first rib. Here you got the manubrium and posteriorly you can see the C7 and the T1 vertebrae. About the attachment of the substance fascia, as I said, it is attached not to the transverse process of T1, it is attached to the transverse process of C7. Let me highlight that so that you don't forget this thing. The attachment is to the transverse process of the C7 and then the fascia will come down, the substance fascia will come down and it is attached to the inner border of the first rib. Look at that. Attached to the inner border of the first rib. That is how our substance fascia or suprapleural membrane is present. So this question is asked like more than twice, and most of the time the question is about the attachment here. Which of the following statement is not true, which of the following statement is true about the attachment, and every time they try to trick on that where it is not attached to. So it is not attached to the T1 vertebrae. It is attached to the transverse process of C7 to the inner border of the first rib. Inner border of the first rib. So this is the fascia, or this is the membrane, the suprapleural membrane, because the pleura will be below that, which is separating the root of the neck structures and the superior mediastinal structure. So this here is the substance fascia or suprapleural membrane. Right? Okay. Now let's talk about the outlet of thorax. Coming to the main thing, that is the outlet of thorax, and that is diaphragm. To understand the outlet of thorax or diaphragm, let us look at a picture of from the atlas first. Let's understand that and then we'll try to replicate the same image. So here we go. This is a picture, guys. This is a picture of the diaphragm you're looking at from the under surface. You're looking at obviously from the inferior aspect, from the abdominal side, you're looking at the diaphragm here. Now things to be noted here. If you look at the diaphragm, obviously clearly you can see it is attached anteriorly to the xiphoid process. It is attached to the costal margin. It is attached posterior to the 12th rib, like this. That is the attachment of the diaphragm on its peripheral surface. Diaphragm is having this whitish central tendon that you're looking at. So we have muscle fiber coming from all the side and we have a tendon in the center, the so-called central tendon. Now, if you first pay attention to this posterior part of the diaphragm here, the posterior attachment, you can see first of all the two crusts here. This here is the right crust of the diaphragm and this one here is the left crust of the diaphragm. Look at this long right crust of the diaphragm here, and that is the left crust of the diaphragm, you can see in there, which is shorter than the right. Apart from the crust, you can see these arc-like structures called as arcuate ligament. This one and this one. We call this as medial arcuate ligament, and this one is a lateral arcuate ligament. Medial and lateral arcuate ligament, which you can see more clearly on this side because the muscles are removed. So you have medial and lateral arcuate ligament. What these ligaments are and how they are formed. Basically, if you look at these medial and lateral arcuate ligament, they are formed by the thickening of a fascia of the muscle present deep to them. Now look at this here. Can you see a muscle here and here? Now guys, this muscle which is present more medially, this is a psoas major muscle, and the one which is present laterally, that is a quadratus lumborum muscle. So I can say that medial arcuate ligament is a thickening of the psoas major fascia only, whereas quadratus lumborum fascia thickening forms the lateral arcuate ligament. Either you call quadratus lumborum fascia or you can even call it thoracolumbar fascia. Same thing. Thoracolumbar fascia covers this muscle. So you can say quadratus lumborum fascia or thoracolumbar fascia, which wraps around this quadratus lumborum muscle, is forming this thickening called as lateral arcuate ligament. Why we need to know about all these? Because when you talk about diaphragm, we talk about certain openings in the diaphragm, the major openings and the minor openings. There are three major openings present in the diaphragm. The one that you see here, which is more toward the right side in the central tendon, it's more toward the right side in the central tendon. That is the opening for the inferior vena cava. Then second opening that you see more or less in the center only, that is the opening for the esophagus. You can say it is in the center, or you can say it is slightly toward the left side, or very slightly, you can see, not exactly in the midline, a bit toward the left side. And then we have an opening which is dead in the center, and that is the aortic opening. So we have a vena cava opening, we have an esophageal opening, and we have an aortic opening. We will discuss all of them in detail. These are major openings. And then we got some minor openings in the diaphragm, allowing the structures to pass through. Like we have a minor opening present just beside the xiphoid process. You can see over there. We call it actually foramen of Morgagni. Then we have, these are the minor openings also. Like there are certain structures which will be passing deep to the lateral arcuate ligament. There will be certain structure passing deep to the medial arcuate ligament. Okay? And you will also see there are certain structures which will be piercing the right crus of the diaphragm. Can you see those nerves? Piercing the right crus of the diaphragm and piercing the left crus of the diaphragm. So they are also considered as a minor openings of the diaphragm. So let's put it in a more schematic way and talk about the attachments of the diaphragm, about the arcuate ligaments, the crus, the major and the minor opening. So everything in there. Okay. So I'm going to go with the same diagram only. So this is how it was. That's a dome that we are looking at. Then we have lateral arcuate, the medial arcuate ligament. This is a long right crus. This is a left crus. There we go. Right? That's how we saw that. So again, you have to presume that you're looking at the picture from the inferior aspect. This is the right crus. And there's the left. Lateral arcuate ligament. The medial arcuate ligament. I told you which fascia they are concerned or related to. So when I say lateral arcuate ligament, it was the quadratus lumborum fascia or thoracolumbar fascia. Thoracolumbar fascia or quadratus lumborum fascia, and medial arcuate ligament is made up of the psoas major fascia. It was a thickening of the psoas major fascia. So that's first thing. Right crus of the diaphragm is longer, left crus is smaller, and then look at the arcuate ligament, lateral arcuate ligament and medial arcuate ligament formed by the thickening of the fascias of the muscle, which are passing deep to them only, present deep to them. Then we said in the center we have the central tendon. Let's say this huge thing in here is a central tendon of the diaphragm. This is the central tendon. And then we said we got three major openings. Now, where was the first major opening? It was on the central tendon, but more toward the right side. So even when you draw it, make sure to draw it toward the right side. I'm writing number 1 here. That's the opening. Number 1, the major opening, but more toward the right side. The second major opening is more or less in the center only. You can say it is like by few millimeters toward the left. And then the opening which is right in the center is between the right and the left crus of the diaphragm, the third major opening. So guys, let's first talk about these major openings and then only we'll go any further here. Major openings of the diaphragm. Now, when I say major openings in the diaphragm, I've numbered them as 1, 2, and 3, which you can remember it like VOA, Voice of America. There used to be a program called as Voice of America, VOA. So opening of 1, 2, 3 is VOA, Voice of America. V here obviously represents what? That is, V is for vena caval opening, O is for the esophageal opening, and A is for the aortic opening. I'm going to write that again. You don't have to write it here. So vena caval, esophageal, aortic opening. And their level at which they open in the diaphragm or present in the diaphragm is, or can be remembered Like vena cava opening is at the level of T8, esophageal opening is at the level of T10, and aortic opening is present at the level of T12. 8, 10, 12. 8, 10, 12. So this is how you can remember the three major openings briefly. That we have first, second, third major opening we're talking about. That's vena cava, esophageal, aortic opening, and their level of these openings on the diaphragm is T8, T10, and T12. Let's take all of these in more detail one by one. Number one opening is V, and V we said is what? That is vena cava opening. V is for the vena cava opening. And this vena cava opening is present in what? It is present in the central tendon. I'll tell you the way to remember it, that where they are present, because again there's a logic behind. You don't have to mug it up, okay, why it is in the central tendon. So there's a reason for that. Now guys, vena cava opening, first of all, what it is giving passage to? Now undoubtedly it will give passage to inferior vena cava, and it also gives passage to the right phrenic nerve. It gives passage to the right phrenic nerve. If you find it difficult to remember that how right phrenic nerve is going through it and why not left is there, well, again, all you have to do is remember the simple diagram of the heart. Now, if this is the right border of the heart, this is inferior border and that is the left border. We all know that right border of the heart is a vertical border. It's a straight border. And this is the superior vena cava, and along this border only we have inferior vena cava. That's how it is. So what you will see, the right phrenic nerve will be descending along the right border vertically downward in this manner, whereas left phrenic nerve has to go obliquely along with the left border of the heart, and then it comes down. So when they go through the diaphragm, now let's say this is the diaphragm here. When they go through the diaphragm, obviously with the inferior vena cava, which phrenic nerve you will see? That's a right phrenic nerve, and the reason is a vertical border. The right border of the heart is vertical. So you can see both right phrenic nerve, this is the right phrenic nerve here, and this one is inferior vena cava. They're running together, they are present in the common opening only. And this also tells me that why left phrenic nerve is longer. We all know that left phrenic nerve is longer than the right. The reason is right in front of you, because it has to first go obliquely along the left border of the heart and then descend downward. And that makes the left phrenic nerve longer also. So there is first major opening, the vena cava opening. The second major opening, guys, it was esophageal opening. That is the esophageal opening. Where is the esophageal opening? Well, either you can say that esophageal opening is present in the muscular part. That is fine. I mean, this was present in the muscular part only. Or you can say it is surrounded. It is surrounded by right crus of the diaphragm. Now you'll be like, surrounded by right crus of the diaphragm? How it is surrounded by right crus of the diaphragm? Well, maybe you did not see the picture carefully, which you will do now. And look at this. If you can see, look guys, look carefully. Look at this second major opening here. Here is the right crus of the diaphragm. If I trace this right crus of the diaphragm upward, this right crus of the diaphragm is going somewhat in this manner. And that's why I'm saying it is surrounded by the right crus. So right crus basically winds around the esophagus and then it descends downward. And imagine still right crus is longer than the left crus. You can very well imagine how long right crus is. Despite of winding around the esophagus, it is still longer than the left here. So either you say that esophageal opening is present in the muscular part, or you will say it is present in the surrounded by the right crus. Both are true. And to help you remember one thing, see, we said vena cava opening is in this one, that is in the central tendon. Esophageal opening is here and aortic opening is here. How will you remember that if there is no confusion between the two? Guys, when you think of inferior vena cava or superior vena cava for that matter, now these are the capacitance vessels. These are the big veins we're talking about. We cannot allow the vein to go through a muscle, because every time the muscle will contract, the vein will also collapse. So imagine if the vein was passing from this opening or anywhere in the diaphragm, apart from this central tendon, then every time the diaphragm will contract, the inferior vena cava will also close. You cannot afford to do that. You cannot close the inferior vena cava. That is why, thankfully, God has gifted us with this opening present where in the central tendon, which is allowing the passage for the inferior vena cava. No matter how much diaphragm will contract, there is no effect, there is no contraction. Central tendon is non-yielding. So it will not, obviously, neither it will stretch too much, neither it will contract. So it will not allow, the collapse of the inferior vena cava. Secondly, when the diaphragm will contract, when the diaphragm contracts, the diaphragm goes down. And when the diaphragm goes down, obviously the intra-abdominal pressure will increase. More intra-abdominal pressure increase means there are chances of that gastric content to come back into the esophagus. And for that, we are gifted with another opening, that is esophageal opening in the muscular part. Because more the muscle will contract, more the diaphragm will contract. This right crus of the diaphragm will also contract, and what will happen? It will close the esophagus. The contraction of this right crus or the contraction of the diaphragm will close the opening for the esophagus and will prevent the regurgitation of the stuff from the gastric, from the stomach into the esophagus. So it's a win-win situation in both ways. So diaphragm going down, intra-abdominal pressure is increasing, your inferior vena cava is still patent and allows the blood to come inside the heart, no problem. But esophagus is also going through the diaphragm, and because of the contraction of the diaphragm, the esophagus will close, which is called as a pinch cock action. This is called as a pinch cock action. So because of that pinch cock action, the esophagus is closed, and thankfully the content from the stomach will not go back into the esophagus. Basically, the purpose of telling you all these details is so that you don't confuse that which opening is where. Don't mug it up. There's a reason behind it. There's a simple basic reason behind it why we have a certain structure going through a certain opening. If I take you back to this picture here, so we're talking about the esophageal opening. The esophageal opening is giving passage to mainly three things. It is giving passage obviously to the esophagus. Esophageal opening gives passage to the right as well as left vagus nerves. Right and left vagus nerve. See, vagus nerve, they run along with the esophagus through the esophageal opening, and as soon as they crosses the diaphragm, they will turn like this. The left vagus nerve will come in front, and the right vagus will come behind, and they form the anterior and posterior gastric nerves. So when you look at the gastric nerves, the anterior gastric and posterior gastric nerve, that's the same vagus nerve continuing down. So it is coming along with the esophagus, and if anything continues with esophagus, that obviously is going in relation to the stomach only. What else we have here? We also have the esophageal branch of left gastric artery. We will discuss that in the abdomen part. Left gastric artery is a direct branch from the celiac trunk, and that left gastric artery also supplies the lower end of esophagus. And that's why from this esophageal opening, you will see one artery ascending upward to come up and supply the lower part of esophagus here. So three things: esophagus, the vagus nerve, right and left vagus nerves, and esophageal branch of the left gastric artery is to be seen. Third major opening of the diaphragm is the aortic opening. Aortic opening. And where is the aortic opening? Aortic opening is present between the crus of the diaphragm. Again, a very strategical location. Vena cava was going from the central tendon because central tendon will not contract and vena cava should not collapse. Esophagus was going from the muscular part because we want to have a pinch cock action on the esophagus. And thankfully, aorta being the largest artery, the main artery which is for the systemic circulation, so obviously the aorta has to go through something which is not affected by the movement of diaphragm above or below. So because it is passing between the crus of the diaphragm, there is an arch which is present between the crus of diaphragm. So it doesn't matter, diaphragm goes down, goes up, contracts, relax, whatever. The esophagus maintain its the lumen, and there is no alteration in the blood flow through the aorta. So it is passing between the crus of the diaphragm. Aorta is giving passage to the aortic opening is giving passage to the obviously to the aorta, that is to the descending aorta more precisely. It also gives passage to the azygous vein. Azygous vein always and sometime hemiazygous also. And sometime hemiazygous, not always guys, not always. Hemiazygous is a different opening. So it gives passage to azygous vein, but sometimes it gives passage to hemiazygous also. And number 3, it is giving passage to the thoracic duct. That largest lymphatic duct we're talking about, the thoracic duct is also going through it here. We'll be discussing all these aorta, azygous, thoracic duct, everything in detail subsequently in the thorax part. So these are the 3 major openings here: the aortic, the esophageal, and the vena caval. Now let's come to some minor openings. Well, though they are minor openings, but in the exam sometimes they become a major question only. So minor openings of the diaphragm goes like we have a minor opening present anteriorly close to the xiphoid process. I showed you that in the picture also somewhere here, and that is what you called as the foramen of Morgagni. We call it foramen of Morgagni or space of Larry also. Foramen of Morgagni or space of Larry's space. And please be careful, guys. It is foramen of Morgagni. It is not the sinus of Morgagni, of course. Sinus of Morgagni is present in the pharynx, in the pharyngeal wall. So this is the foramen of Morgagni or the Larry space. And this foramen of Morgagni or Larry space is giving passage to the superior epigastric vessels. It is giving passage to the superior epigastric vessels. Superior epigastric vessels. Superior epigastric vessels or superior epigastric artery is a branch of internal thoracic artery. Again, something which we will discuss in a while. And again, please be careful. It is superior epigastric, not superficial epigastric. Superficial epigastric artery comes above. That is a branch of external iliac which will come above. That is superficial epigastric. Superficial epigastric artery, branch of femoral artery, sorry, that we will discuss in the roof of the femoral triangle. That is coming above. This is the one which is going down. It is superior epigastric. Okay, another minor opening are the crus of the diaphragm here, the right crus and the left crus. Now, what is the crus of the diaphragm giving passage to? Both the crus of diaphragm are giving passage to the nerves called as the splanchnic nerves. We call them the right and the left splanchnic nerves. I'll tell you a bit more about it. Just draw these nerves and leave it for now. And another minor opening is the structures passing deep to the arcuate ligament. Now, passing deep to the medial arcuate ligament is this sympathetic chain. You can draw it in this same diagram only. So you will see the sympathetic chain passing deep to the medial arcuate ligament. That's how it goes down. And deep to the lateral arcuate ligament, you will see subcostal nerves and vessels. You will see subcostal vein, subcostal artery, and subcostal nerve. Van, V-A-N. I hope this is van. This is subcostal. Subcostal vein, artery, and nerve. Lateral arcuate ligament is present at the level of the 12th rib. So obviously below the 12th rib, you will see the 12th nerve and artery and vein only. So we call them subcostal nerves and vessels. Just for a quick comparison, if I just again take you back to this picture, look at that. Although you cannot see the subcostal nerves and vessels, they did not draw it in this picture, but you can see the sympathetic chain at least. Look at the sympathetic chain coming deep to the medial arcuate ligament only. And you can even see these nerves. Look at these nerves which I'm like putting a circle here. These are the splanchnic nerves I was talking about. The right and the left splanchnic nerves, the visceral nerves. These are sympathetic nerve which do not relay in the sympathetic chain. They simply come out of the sympathetic chain to relay in the ganglion close to the organ only, like celiac ganglion and aortic-renal ganglion, other ganglions like these. So they are sympathetic nerve. You will see them coming out of sympathetic chain only, but without relaying in the sympathetic chain. They just simply come out of the sympathetic chain without relaying there. Let me write this thing also finally for you. That is the arcuate ligament I was talking about. This crus here, that is a right crus. And this is the left. So as I said, both the crus are giving passage to these splanchnic nerves. Splanchnic word actually came from the visceral nerves. So these are all right splanchnic nerves. Now splanchnic nerves, we have a greater splanchnic, lesser splanchnic, least splanchnic. We'll discuss that not here. We'll discuss them in the neuroanatomy part. And these are the left splanchnic. And additionally, from the left crus of diaphragm, you might also see the opening for hemiazygous vein. Hemiazygous vein. I told you hemiazygous vein can be seen going from this aortic opening only in the center. But most of the time, hemiazygous vein, it pierces the crus of the diaphragm to go above. So azygous vein is definitely there here in between the two crus. But hemiazygous vein, sometime through the crus, sometime through the same aortic opening. So this is about the right crus and the left crus of the diaphragm. So guys, this is basically about the major openings and the minor openings in the diaphragm. Well, needless to say, we all know that diaphragm is supplied by phrenic nerve, but one interesting fact that you should note, that is there anything in the diaphragm which is supplied by both phrenic nerve, right and the left? Now we know obviously right phrenic nerve will supply the right dome, left will supply the left dome of the diaphragm, but do we have anything in the diaphragm which is supplied by both the phrenic nerve? And the answer is again very evident in the picture here. If you look carefully, let me just rub everything else so that you have a clear view. Now, can you see this right phrenic nerve here? I'm just marking that. That's a right phrenic nerve there. And this one you can see there is a left phrenic nerve. And if you look carefully, this here is what? That is a right crus of the diaphragm. And a right crus of the diaphragm, if you see, it slightly goes toward the left side and then it descends down from the right side. So in a way, I can say that the right crus of diaphragm, it is present. It starts from the left side and then comes toward the right side. And that's why you see the branches of the right phrenic nerve coming to this. You can see it here. And you can see the branches of the left phrenic nerve also coming to it. So please note that the right crus of the diaphragm is one structure of the diaphragm which is supplied by both phrenic nerve. Please note, right crus of diaphragm is supplied by both phrenic nerves. Supplied by both phrenic nerves. So this concludes the first thing for us, that is the inlet and the outlet of the thorax.